if we give a drug by IV route, intravenous route, what is likely to be bioavailability? Obviously, it is 100%. So, bioavailability of all the drugs by IV route is 100%. So, whenever we give any substance by oral route, after absorption, it will reach first of all liver via the portal circulation. Through the portal circulation, everything reach the liver first. So, when we give a drug, like we give any drug 100 molecules by oral route, so these will also come into liver. Suppose we give 100 molecules, and out of the 100 molecules, suppose 20 molecules are not absorbed and they are excreted in the feces as such. So, rest of the 80 molecules will be absorbed and go to liver. We will say absorption of this drug is 80%. So, 80% drug reach the liver. But we do not want the drug in the liver. We want the drug in systemic circulation, because finally the effect will be produced by the drug which is present in the systemic circulation. So, this is blood or systemic circulation. So, these 80 molecules which have been absorbed, they should reach the systemic circulation. But before the drug reach the systemic circulation, some of the drug is broken in the liver. Like out of 80 molecules, suppose 30 molecules are broken in the liver. So, only 50 molecules will reach the systemic circulation. Now, if we see carefully, we have given 100 molecules by oral route, but out of that only 50 molecules will be able to produce the action. 100 molecules are given, but only half of them, that means 50%, will be able to produce the action, or in other words we can say only 50% is available to produce the action. So, other way of saying this is only 50% molecules are biologically available. So, this fraction is known as bioavailability. Bioavailability. So, we can remember this concept, biologically available. So, whatever drug we have given, how much percentage is biologically available to produce the action is called bioavailability, or in simple words, it is the fraction of given dose which reach the systemic circulation. So, the obvious clinical importance of bioavailability will be, if a drug has higher bioavailability means more drug is available to produce the action. If a drug has lower bioavailability means less drug will be able to produce the action. So, that means bioavailability will determine the dose of a drug. If bioavailability is high, we can give low dose. If bioavailability is low, we have to give high dose of a drug. Now, from this discussion, we can also find out which factors affect bioavailability. Now, you can see that in this example, bioavailability is 50%. Now, why it is 50%? Because rest of the 50% is wasted. So, where it is wasted will determine the bioavailability. So, we discussed two main areas where the drug is wasted. One is here and second is here. That means 20% of drug is not absorbed, or in other words we can say 80% is absorbed. So, the main factor affecting bioavailability is absorption. If a drug has more absorption, it is likely to have more bioavailability. On the other hand, if a drug has less absorption, obviously the bioavailability will be less. Now, the second factor affecting is this metabolism, and this metabolism which is occurring is called as first pass metabolism. The other term for this is pre-systemic metabolism. So, bioavailability will depend upon pre-systemic metabolism or first pass metabolism. If first pass metabolism of a drug is high, what will happen to bioavailability? Obviously, it will be lower, because if out of 80, 30 molecules are broken, then 50% will reach. But if out of 80, 70 molecules are broken, then only 10 will be able to reach the blood. So, first pass metabolism, if it is higher, bioavailability is likely to be low. One last thing, if we give a drug by IV route, intravenous route, what is likely to be bioavailability? Obviously, it is 100%. So, bioavailability of all the drugs by IV route is 100%. Okay. Now, to understand the importance of first pass metabolism, we will take an example which is very good example. It is nitroglycerin. Nitroglycerin is a drug which has almost 100% absorption. That means when we give nitroglycerin by oral route, nothing is excreted in the feces. Almost all 100% reach the liver. So it should have good bioavailability, but no, it has very poor bioavailability. The reason is it has almost 99% first pass metabolism. That means when we give nitroglycerin orally, although almost 100 molecules reach the liver, but 99 molecules are broken in the liver and only 1 or 2 molecules are able to reach the systemic circulation. So if we give nitroglycerin by oral route, it is likely to have poor bioavailability. So we use it by alternative route, and that route is called sublingual route. Sublingual, as the name tells, lingual means tongue. Lingual means tongue, sub means below. So in sublingual route, we keep the tablet below the tongue. Now on the under surface of tongue, there is presence of a vein called lingual vein. In the under surface of tongue, there is a vein called lingual vein. So when we keep a tablet below the tongue, means we are keeping it over the vein. So now the drug can directly go into the systemic circulation. So when we give nitroglycerin by sublingual route or any drug by sublingual route, it will directly reach the systemic circulation. So what will be the advantage? There is no first pass metabolism. The main advantage of this sublingual route is there is no first pass metabolism. Any other advantage of this route? Now you can see from the diagram very clearly, when we give a drug sublingually, it will directly reach the systemic circulation. On the other hand, if we give a drug by oral route, first of all, it will reach the esophagus, stomach, intestines. From there, it will be absorbed and it will go to liver. And from the liver, it will go to systemic circulation. Then the action will come. So that means oral route, the drug will take around 40-50 minutes to act. But by sublingual route, the action will start in few seconds only. So sublingual route, the main advantage, it is very fast acting. And what is the advantage of fast action? Advantage of fast action is we can use the drug in emergencies. Nitroglycerin is used in acute attack of angina, which is an emergency, by sublingual route. Now, any other advantage of sublingual? Now, asking the question in other format, can we give nitroglycerin by IV route, intravenous route? Yes, we can give IV, but we commonly do not use IV. The reason is every person do not develop angina at hospital. Most of the time angina occurs at home. So when the angina occurs at home, we have to treat at home. And for giving intravenous injection, we require some expert person who is well versed with the technique of IV injection. And these doctors or nurses are not available in every home. So we have to take the patient to hospital, and that will spend around 20, 30, 40 minutes, which we do not have. Whereas in sublingual route, the main advantage is self-administration is possible. The person has to keep the tablet below the tongue, which anyone can keep. So there is no requirement of any assistant. Self-administration is possible. That is the major advantage of sublingual route. And lastly, one main advantage of sublingual route is we can take in this manner. Suppose we give 5 milligram of nitroglycerin by sublingual route. When we give sublingually, suppose out of the 5 milligram, 3 milligram reach the blood, and now the chest pain subsides. Angina is treated. Now what happened to rest of the 2 milligram? Rest of the 2 milligram is still in the mouth, so we can spit it out. Okay? So whenever the desired action is obtained, we need not take the extra drug, we can remove that drug. And this is not possible with the oral route, because if we give 5 milligram by oral route and suppose 100% bioavailability is there, and if 3 milligram is absorbed and now the action comes, what happened to rest of the 2 milligram? We cannot control, because even that will be absorbed and we cannot stop that. So excessive dose we can control in case of sublingual route. Whenever desired action is obtained, person can spit the extra amount of the drug. So desired dose we can use. After that, we can spit the drug, or what we commonly advise in case of nitroglycerin is take the tablet sublingually. Whenever the chest pain subsides, either spit the drug or ingest the drug. So what will happen if a person ingests the drug? Almost all will be first pass metabolized. So basically we can terminate the action. So four main advantages of sublingual route are: number one, there is no first pass metabolism. Number two, we can use in emergency because of quick action. Number three, self administration is possible. And lastly, we can spit the extra dose whenever the desired action is obtained. So we discussed bioavailability. It not only depends upon absorption but also first pass metabolism. Now we will try to discuss how to measure bioavailability or how to calculate bioavailability. Suppose we want to calculate the bioavailability of drug A. Someone asked you the question, tell the bioavailability of morphine, or tell the bioavailability of aspirin, or tell the bioavailability of any drug XYZ. Can you tell? You ask me any drug, I can surely tell exact. Like if you ask me, tell the bioavailability of morphine, my answer will be bioavailability of morphine by intravenous route is 100%. Obviously. So any drug when we give by IV route, bioavailability will be 100%. So the question tell the bioavailability of this drug is wrong. The question should be tell the bioavailability of drug A by oral route or by intramuscular route. So we need to specify the route. Without the route, telling the bioavailability does not make any sense. Okay? So we need, now our question is tell the bioavailability of drug A by oral route. The problem here is when we give a drug, we give in the units of weight. Like we give the drug 100 milligram or 100 microgram or 10 gram. So we are giving the drug in the unit of weight. But when we measure the drug in the plasma, we measure in the unit of concentration. Like plasma concentration, if it comes, is 100 microgram per deciliter. So that means we are giving in a different unit and we are measuring in different unit. So first of all, we should know that when we give a dose, particular dose, if entire dose comes in the plasma, what will be the plasma concentration? Suppose when we give 100 milligram, if entire drug comes in the plasma concentration will be 100 microgram per deciliter. Now we give by some route and the plasma concentration comes out to be 80 microgram per deciliter. So we can safely say that 80% has reached the plasma. So that means bioavailability is 80%. But for that we need to know if all the drug come in plasma, what will be the plasma concentration? That means if the bioavailability is 100%, what will be the plasma concentration? So by which route bioavailability is 100%? Yes, intravenous route. So for calculating the bioavailability by any route, first we need to give the drug by intravenous route because we want to know the 100% first of all. Clear? So what simple terms what we do is, suppose the question is calculate the bioavailability of drug A by oral route. So what we do is, first of all, we will give any fixed dose of drug A, suppose 100 milligram by intravenous route. First of all, we will want to give it by IV route to know the 100%. After giving intravenous, we will plot a graph between plasma concentration and time. A graph is plotted between plasma concentration and time. So we will keep on measuring the plasma concentration every half an hour and we will plot a graph. So the graph will come like this. Because the drug is given IV, initially concentration will be very high. But gradually it will start decreasing. So this total area represents our 100%. So this is our 100%. And this we can say is area under the curve. AUC, curve means plasma concentration time graph. Area under the curve by IV route. So this AUC IV represents our 100%. Clear? Now when the drug has become almost negligible in the plasma, now we will give same drug A, same dose 100 milligram, but by the route for which we want to calculate the bioavailability. So that means now we will give drug A 100 milligram orally and again we will plot the same graph. That means keep on measuring the concentration every half an hour. Now the graph will come like this because we have given the drug orally. So slowly the plasma concentration will increase, become maximum, and then it will start decreasing. So this area is called as area under the curve for oral route. Clear? So we calculate two areas, one by IV route, another by oral route. And now we can safely say what is bioavailability. Yes, bioavailability is area under the curve by oral route divided by area under the curve by intravenous route. Clear? This will come as fractional bioavailability. It will come in points, 0.2, 0.3, 0.5, 0.7. If you want to calculate in percentage, multiply it by 100. Or simply 0.2 means 20%, 0.8 means 80%. Okay? So this is how to calculate the bioavailability. Clear? Now related to bioavailability, there is another concept known as bioequivalence. Bioequivalence. First question, what do you mean by the term bioequivalence? So we will divide it into two parts. Bioequivalence. So it says biologically equivalent, means these are similar. So when we are saying they are similar, means we are talking about more than one thing. Obviously, when we say this is similar to what? So obviously we are talking about more than one thing. So here we are talking about two things. Which two things? The two things we are talking about are two brands of a same drug. Remember, one drug may be manufactured by 10 different companies. So when we are comparing the same drug of one company with another company, here the term comes as bioequivalence. So bioequivalence, as the name says, if the two brands have almost similar effect, they are called bioequivalent, means biologically equivalent. Clear? We can take the example. Like there is a drug called as aspirin. We all know aspirin. Different manufacturers are making this drug. Suppose one manufacturer make this as ecosprin, another make it as losprin. And suppose both of them contain same amount of aspirin, suppose 150 milligram. Both are containing same amount of aspirin. When we give ecosprin to a person and measure the plasma concentration, the plasma concentration comes out to be 100 microgram per deciliter. Remember, these are all hypothetical values. Okay? And when we give losprin, the plasma concentration comes out to be 90 microgram per deciliter. Are they bioequivalent? No. Suppose instead of 90, we make it 95. Are they bioequivalent now? Suppose instead of 95, we make it 99. Are they bioequivalent? Suppose instead of 99, we make it as 99.999999. Are they bioequivalent? So obviously, we need to draw some line, because even if we give ecosprin to two different person or same person after some time, the plasma concentration will not be exactly same. Human body is a biological tissue, so there will be some variations. So we must allow some variation, and that allowance which is seen is plus minus 20%. Means if ecosprin is giving a plasma concentration of 100, then losprin, if it is between 80 to 120, we will consider it as bioequivalent. If it is less than 80, not bioequivalent, more than 120, not bioequivalent. So bioequivalence means if the two brands of a same drug has almost similar bioavailability. Similar means plus minus 20% is okay, but it should not be more than that. Clear? Now most of the drugs which are present in the market now, they are bioequivalent, because now whenever any new company want to make the existing drug, they have to show that it is bioequivalent to the original drug. So bioequivalence studies are done, only then the drug is approved. So most of the drugs which are existing in the market are bioequivalent, but you need to remember one exception, and that is phenytoin. Different brands of phenytoin are not bioequivalent. Like we can take the example, two brands of phenytoin are there. One is dilantin and second is aptoin. No need to remember the brands. This is just an example. Suppose both of them contains 300 milligram of phenytoin. A person has epilepsy. We know phenytoin used for epilepsy. Person has history of seizures, and the person was started on dilantin, 300 milligram phenytoin, and the person is well controlled. Person is taking this drug since 6 months. No seizure has occurred. Person is totally controlled. After 6 months, the strip of phenytoin finishes, and this person go to pharmacist that give me phenytoin, dilantin 300 milligram. So the pharmacist says that I do not have dilantin, I have Aptoin. You can see Aptoin also contains phenytoin 300 milligram. So you can use that. So that person start taking Aptoin, 300 milligram phenytoin. But on third day, the person developed seizure. Why this happened? Because phenytoin and the different brands of phenytoin are not equivalent. So dilantin and Aptoin are not equivalent. So Aptoin may not give same plasma concentration. So phenytoin shows the phenomenon of non-bioequivalence. So means in case of phenytoin, brand change is not recommended. If we change the brand blindly, the drug may not be effective or the drug may be even toxic, because we do not know that what plasma concentration will come from that brand. So different brands of phenytoin are not bioequivalent.